Hello and thank you for joining in on today's training. Heart & Solutions is a proud provider of CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below to find and take your quiz.
Thank you everyone for being here today. My name is Natalie Queen and I am a therapist here at Heart & Solutions. I am super excited to be hosting this training with You Need a Training today. Before we begin this morning, I'm just going to take a few minutes to review a little housekeeping items. As a quick reminder, everyone attending the training must be individually registered. If you're joining with a friend and you haven't registered yet, you won't be able to access the CE certificate or get credit for the training today, or credit for attending today. So if you have registered individually but are joining together, you will need to open the Google Meet link individually in order to get credit for attending and be able to complete the CE quiz. For those that have attended a training with us before, you will see that we are on a new platform. If you do have any questions about how to access things, please let us know. I'll be tending the chat today. All materials for today's training can be found in your course page by clicking on the paperclip in the top right corner. After the training ends today, you will be able to access the CE quiz. You will not be able to access that until the training concludes today, so don't worry if you're unable to click on it right now. After you complete the quiz, your CE certificate will then be automatically generated for you. Without further ado, I'm going to introduce our guest. So today's training is being presented by Dr. LaVerne Collins. We have a quote here that is is this from your book?
No.
Okay, but this is just a quote by Dr. Collins. It's guided by faith, cultural wisdom, and mental health expertise. I dedicate my work to transforming struggle into strength, overlooked stories into visibility, and personal growth into collective impact for a more compassionate world. Dr. Collins is a nationally recognized counselor, educator, author, and speaker whose work bridges mental health, multicultural competence, and leadership development. With more than 30 years of professional experience, Dr. Collins has trained and mentored clinicians and organizational leaders through continuing education, clinical supervision, and multicultural consulting. Her approach integrates cultural humility, faith, and evidence-based practices to promote healing, growth, and equity across personal, professional, and institutional levels. Dr. Collins is the author of Overlooked: Counselor Insights for the Unspoken Issues in Black American Life, and The Fruit of Your Pain: Experiencing Spiritual Renewal Through Seasons of Struggle. Her thought leadership has been featured in the U.S. Times, USA Leaders, The Women's Insider, the CEO Times, and many other outlets. As a national certified counselor and professional counselor who holds licensure in 4 states, she brings both clinical and academic expertise to her role, ensuring that all new seasons programs meet professional, ethical, and multicultural standards of excellence. With that, I'm not going to take up any more of this valuable time. Dr. Collins does have a video that we are going to start us off with, and then we'll get started with the training.
Good morning, everyone. Aiming treatment at the right target, commonly overlooked diagnostic errors with Black and clients of other races. Thank you so much for the kind introduction. I am LaVerne Collins, and going to be with you through this 3-hour training, this presentation. This is content that is very close to my heart. The reason I begin with the video is because this is part of the Overlooked No More training series. And for more content focusing on the things that we miss, the things that we have been taught, we have not been taught to find, the nuances we were not taught to address in most of our graduate training programs. Excuse me. These are the kind of things I talk about in Overlooked. Forgive me. You saw in the little video there, overlooked identity issues, overlooked historical factors, overlooked clinical bias, and that's the section that we're going to be pulling from today, but also overlooked losses and overlooked strengths. We want to be in the overlooked no more provider category. And it's my pleasure to be with you today to help bring to light some of the things that I learned, shall I say, the hard way. I graduated from a wonderful CACREP accredited program at the master's level, and it was only when tragedy struck my own family that I recognized that I had not, even though I had that one credit counselor, multicultural counseling course, I had not been trained to provide services to my own community, to my own family. I was taught a very one-size-fits-all model. And we addressed cultural competence as understanding a group of people almost as a monolith, without getting into the individual nuances of what it means in the United States to be a person who is a part of a racialized or minoritized or otherized group. That's changed somewhat, but I know there's more emphasis on that in master's degree programs now. But for those of us who've been in the field a long time, we didn't get the perspectives that current graduate students and new licentiates, so to speak, are getting. So I enjoy doing continuing education for people who have been in the field for a while and are passionate about being the best counselor they can be for everybody. With that in mind, our objectives for today are to first discuss a range of disparities that we see backed by research from the perspective of race and gender. I want to explore reasons why we have these tendencies for misdiagnosis, and especially among Black men and boys. That's where the research shows some of the most significant disparities. And then, of course, we got to talk about what we can do to avoid those race-based diagnostic errors. So I hope you'll enjoy today's work and the conversations that we will have. As has already been spoken, you will have, just consider this an open mic thing. So just put your comment in the chat, and Natalie's going to monitor the chat for me. Or if you raise your hand and I don't see it, Natalie, just chime in and say, we have a hand. And I'll be happy to take your comment or question. A couple opening position statements, and I'll tell you why I do this. I want to do a level set to make sure that we are all on the same page with why I'm coming from the direction I'm coming from with some of this content. So the first thing, and this is the big one, I believe that culture and race have to be moved from the background to the foreground, no matter how uncomfortable it makes us. The more we bring with intentionality this kind of content front and center in the session, in our relationship, the more we gain confidence in seeing culture and race and identity data as clinical data and not as a background data, the more effective we will be and the more comfortable we will get with those kinds of positions when we're working with people who don't look like us. Number two, cultural humility over cultural competence. I believe, as many of my colleagues in this multicultural space are proposing, that we ditch the word cultural competence and that we just begin to think about cultural humility. Cultural humility says, this is the way that I see it. That may not be the way others see it. And I don't need to pathologize the way they see it. I don't need to pathologize how they survive. I don't need to pathologize how they grieve. I don't need to pathologize their support systems, their safety networks. I don't need to pathologize. I need to recognize. And that means that I have to acknowledge that my way of handling a situation or my way of communicating or whatever makes me me is not the only way. So there is an element of humility there. Cultural competence suggests that you go down this checklist and you learn certain things about certain populations and you group people together as having certain beliefs, but there's not a single identity group, in my opinion, that is a monolith. So competence, if we're not careful, when we speak of cultural competence, it will lead us to creating stereotypes and check boxes and thinking that, okay, now I know about them. Well, cultural humility is not about learning about a group of people. It's about positioning yourself as a learner, positioning yourself as a person willing to respect and honor what is different from yours. Positioning race-based trauma above ground. Any identity trauma above ground. And I'll show you a model that I use, and I hope you will find it helpful as well, that I use to bring trauma from the invisible realm to the visible realm. And then I believe that diagnosis should never happen in a vacuum. Diagnosis always has to be considered in the context of culture. Otherwise, we can be aiming our treatment at the wrong target. We can be imposing our value system in a clinical way where it's just not helpful, not productive, and maybe not even ethical. So we don't want diagnosis to happen in a vacuum. What do I consider a vacuum? You'll see. If we consider diagnosis only through DSM, and I know we have to use DSM to get paid, but if you're only looking at DSM, you are looking at a diagnosis in a vacuum. So those are my opening position statements. Those are things that I consider to be foundational when I'm training supervisees or when I'm training through my business. I do lots of CE trainings, and I actually also have a multicultural masterclass because I want to raise up people to do what I do, which is not just see what I see, but train others in these same concepts. So anytime I'm training, I am positioning where I'm coming from. And this is where I'm coming from in our space today. Thoughts or questions about that? So let me explain all of that. Culture can be treated as either background or foreground. When we treat culture as background. We're saying that if a person with a different racial or cultural identity or gender identity is sitting in this space with you, you can treat that as optional and tangential if you're treating culture as background, because it's just a background narrative. This is the view that says we're all human and we all experience emotions and we all have difficult seasons in our lives, and culture is just one of the many forces, one of the many aspects that shapes life, and you can choose to either include it in your conversation or not. But when you treat culture as foreground, you recognize that culture is central and necessary, that racial identity is central to a person who comes from a racialized community. I can't go anywhere and the color of my skin not be at the forefront of my mind, because I recognize that when someone looks at me, they see an African American woman of a certain age. And I am proud to be that. I also recognize that sometimes, in many cases, in most cases, that is not the privileged identity in the room when there are multiple identities in the room. I am always aware of that. There's not a single thing I do that, when I consider my identities, which I would say is a African American, female, over 50, mother, wife, grandmother, mental health professional, business owner, counselor, trainer, minister in my church, whatever, all those identities, I'm always an African American female. I'm not, and that's not a role, that's an identity. I'm always a mother and a wife too, but those are roles as well as identity. Black and female are not roles. They're constant. I don't step in and out of that. I don't go into a session with my therapist and leave that at the door. It is an overpowering foreground narrative for a person of color. So when I would treat culture as foreground, it means we're discussing my emotional problems in the context of perhaps domination, perhaps constraining self-definitions that are imposed on me by the way I've been socialized, whether racism is coming at me from an institutional or systemic or interpersonal perspective, or whether I'm experiencing internalized racism because of messages that I've received and things that I have come to believe about myself or my race. Culture is foreground, and we would discuss whatever's going on in my life through that lens. Now, people say, how do you do that? How do you do that, especially if you're looking or talking to a person with a different racial identity? How do you do that and not offend? Here's how I start my sessions. So tell me, as an African American man in today's world, how you doing? You see, I invite them to tell me how they're doing in the context of that identity. Or I'll say, hey, lady. And I am just like that because I believe that our rules about professionalism often become unethical when they don't allow you to meet a person where they are from an identity standpoint, and that sometimes our professionalism becomes unethical because it quashes identity and culture. So if it's someone I've been working with for a while and we have we've built the rapport around culture, I'll say, hey, lady. So as a Black woman, how you doing? How you doing personally, professionally, with everything going on in our world. How are you? So I am bringing that into the space and saying, for everything we talk about, I'm interested in how your identity shapes your experiences, influences your experience, makes it better, makes it stronger, makes it weaker, introduces new problems, difficulties, struggles, whatever it might be. Bring that. That's like me saying, bring it. Bring your identity. Bring your identity in all its glory, and let's talk about it. Or in all its pain, and let's talk about it. Foreground has to do with visibility and validation, because members of marginalized or racialized groups have the experience of invisibility on a regular basis. And you have to let that's a reality that has to be lived. Sometimes I hear women of any race speak about feeling invisible in predominantly male spaces. But certainly the experiences of people of color are generally outside the range of awareness for people who don't live those experiences. So the invisibility, do you see me? Do you really see me? I don't appreciate the as much as I understand the honest intent behind it for most people, the colorblind expression when it comes to race is not something that I really appreciate. I want you to see. I want you to see me. I want you to see me. I'm a beautiful African American woman, over 50, over 60, in fact, and I have a history. I'm a proud descendant of enslaved ancestors. I am not proud of slavery in America, but I am proud that my ancestors survived. They survived. You gotta look at me and see the survival in my genes. You gotta look at me and recognize that I traverse spaces that everyone doesn't have to traverse. I hear the news in ways that other people who don't share this identity don't hear the news the way I hear the news. And certain privileges I don't have, and I'm not talking about privilege in terms of economics or even race privilege. Well, partially race privilege, but I don't have the privilege of being able to not notice things. You can't let that remain invisible in your world as a therapist. The other reason why we bring this into foreground is because the experience of invalidation. People of color and other marginalized groups have to function in an ethnocentric society that either intentionally or unintentionally invalidates their experiences. A lot of gaslighting. I get a lot of gaslighting. Oh, you sure that's what they meant? Oh, I'm sure that's not that's not what they intended. That's not what they meant. And I'm just gonna be real. Sometimes I don't care what you meant. I might not hold it against you, but the first thing that hits me is how it came out, how it hit me. And when I say how it hit me, and the response is an invalidating response, we're not going to have the therapeutic rapport that makes me feel safe. And again, now we're getting into ethics. Getting ready to do a whole series, a 3-part series on decolonizing professional ethics in mental health. I'm enjoying putting this together, because if you use a monocultural lens, anything that is ethnocentric becomes potentially an ethical dilemma or an ethical even violation. So we're going to aim our work at the right target, you've got to invite the whole person into the space, the whole person. And that's why cultural humility is a stronger position than cultural competence. Cultural competence is content oriented. And again, you're looking to learn about various cultures, but cultural humility is process oriented. And what you're aiming to do there is enhance your ability to deliver client-centered care without otherizing. Remember your cultural competence? Well, we do this, but they prefer that. And we may do this, but they, cultural humility avoids that otherizing, the we, they paradigm. And that's where we need to live. With competence, you're learning supposedly about beliefs and values and behaviors, but that's not the same as learning about lived experience. In cultural humility, you are orienting your care based on an appreciation of that person's lived experience. You're open to sharing power. People will sometimes say to me, now, how do you, and I see you have your doctorate, how do you prefer to be addressed? And a lot of my African-American colleagues would say, Dr. Collins is fine. And I don't fault them for that. They want to be respected. They want their degree and their training to be recognized and honored. But for me personally, I say, what's comfortable for you? Don't call me out my name, but what's comfortable for you? What am I doing there? I'm inviting shared power. I'm an African-American female, just like you are, or a female just like you, or a human being just like you, you know, right? I'm a human being just like you. What's comfortable for you? People have different experiences with titles and the authority or the expectations that go with certain titles. So I share the power by saying, you can use a title if you choose or not. Many people will say, no, I want to respect who you are. I want to respect the education you have, the knowledge you have. I want to say Dr. LaVerne or Dr. Collins, and that's fine. Others say, well, yeah, I like to be just casual, LaVerne, and that's fine. That's fine too. That in itself is an equalizer for people that need that. And we don't often think about the fact that when people come into our space, they're ascribing things to us that we don't know about. We don't know what they're ascribing to us because of our position, our race, our title, whatever. Shared power and continued learning with the understanding that people are coming in with a lived experience that's influencing how they see me as a person of authority, power, whatever. Competence presents the risk of stereotypes. I'm going to get through this. I'm going to rush through this a little bit faster. Cultural humility examines the things that we've learned. It examines our biases, our approaches, our presence, our assumptions. And the interrogation that we do is into our own perspectives. We're interrogating ourselves about our imbalances and our expectations of other people. Because as we talk about aiming treatment at the right target, provider bias, you'll see when I get into these other slides, you'll see where provider bias is messing people up because of expectations and stereotypes and even personal history. Okay. I said that it's important to bring trauma, histories, and pain into the visible, into the addressable, And we all know how hard that can be, because people are referred to us based on a problematic experience, a symptomology. So I have this tree, I call the tree of overlooked racial trauma. Now, you've probably seen trauma trees before, but this one deals with racial trauma, identity trauma. So take a look here. For my tree, the leaves and the fruit are the behavior, the limbs are the diagnoses, because we know that a diagnosis is nothing more than a set of behavior, symptoms, features, or problems that sit together. And when you have a certain number of them, you have enough to make the diagnosis. So when the limb, when at the end of this limb are these certain cluster of problems, that creates a diagnosis. The trunk for me is bodily system stress that leads to a diagnosis that produces those behaviors, features, symptoms, and problems. And underneath the surface, underneath the ground, are the roots. And the roots are the overlooked traumatic experiences. You'll see what I mean when I talk about aiming treatment at the wrong target. Because when you look at what we treat, shame, somatic symptoms, fear, resistance, anger, distrust, blame, worry, those are all, problems, anger. And anger management is one of the worst things you can provide for a person who has experienced significant traumatic events. They're going to fail every time. They're going to fail every time, and I'll explain why in a little bit. But we put our emphasis on the behavior and the diagnoses. The PTSD, the depression, the anxiety, the substance use, the dementia, the autoimmune disorders, even the hypertension. We're putting our attention on what we see at the top of the tree. But what we see at the top of the tree, where does it come from? It comes from psychological stress. It comes from oxidative stress. It comes from the stress on our endocrine system, our hormones. It comes from inflammation. Did you know that even depression is tied to inflammation? Some people know that, some don't. We are admonished in DSM to rule out general medical conditions. But how many of you require a person to, when they come for counseling, how many of you put in their treatment plan the admonition to see or the requirement to see a primary care physician, so they can get some of this stuff under control too? Because we know the body holds the score, keeps the score, right? The body holds the trauma. Will you look at that? Examples, just a few examples of racialized trauma that's invisible to those who don't have these experiences. You don't think about the fact that one person could have experienced all of this: microaggressions, racial battle fatigue, criminalization, stereotyped judgment, disenfranchised grief, which is grief that occurs when you lose something that society doesn't recognize as a loss, maybe dignity, maybe opportunities. Early death losses. The expected lifespan, life expectancy of an African American male born in 1960 is only 61 years old. She's 61. Because I'm over 60, lost a lot of males in my circle already in their 50s, maybe 61, maybe 62. What does that mean? Children lose parents and siblings. Parents lose children. We lose first-degree relatives. In the Black community, you will have lost several first-degree relatives before you're 21, or second-degree relatives. I'll say family by the time you're 21. A white person is exponentially more likely to even get to 60 without having lost a close relative. So early losses. Is there adverse childhood experiences? Let me keep going. False accusations. The heavy impact of COVID. Black and brown populations got hit really hard. My husband lost an aunt and his cousin. Lived in the same house together. The elderly aunt, the daughter who was taking care of her, they both passed away from COVID in the same home. I'm not saying the whole world was impacted by COVID, but in the United States especially, Black and brown people were affected at significantly more notable rates. Discrimination, medical racism, the presumption of guilt, racism, hate crimes, historical trauma. Those things that we overlook. And if I don't say at the beginning of my session, how are you as an African-American woman or Black woman, however they prefer, some prefer Black, some prefer African-American, but how are you as a Black woman? How you doing in light of everything that's going on and the many ways in which we're dealing with stressors and division? How are you doing? That invites a person to tell me about what's happened in the past week or over the course of their lifetime with these blazing red events, the red zone events. I'm inviting that. I want to hear that. I want them to give me that. I want them to tell me that. Here's the thing. Rumi, great philosopher, said, maybe you are searching among the branches for what only appears in the roots, aiming treatment at the right target. If you're only looking at the branches, the diagnoses and the behavior, you might be missing what really needs to be healed. We want to heal the root so the tree can be stable. Heal the root so the tree can be stable. The story of Anne. Well, let me before I go into Anne's story as an example of this. Questions, comments. Natalie, anything in the chat?
Nothing in the chat. I have a whole list of notes here. I'm getting so much good information. So no questions so far, but there are a lot of things that are really helping me because I have a few clients where I feel like this would be really important for me to address or kind of tweak my own clinical approach with. And yeah. I'm loving all the information.
Okay, great. Well, just holler out if there are questions or at any point in time. So the story of Anne. I just want you to listen to this, and I'll tell you how we're going to talk about it, how we're going to discuss it, but just listen first.
We were traveling with my father in the car late at night, and there's a road that was long and dark. And my father did what no Black man at the time was supposed to do. He allowed his car to run out of gas. He ended up pushing the car, and the only place he could get to was a white truck stop with the white only signs up. And he went up to the door and he just knocked at it. And the guy came up and he said, "What are you doing, nigger? Get away from here. Can't you read?" And My dad, he took his hat and held it in his hand, trying to make himself small because he was kind of a tall man. And he said to the guy, I see your sign, sir. I'm sorry. I'm not trying to disturb you or your business. I just got my young kids in the car, and could I just buy a couple of gallons of gas? And the guy said, I don't deal with your kind. And he stepped back and he slammed the door. I saw my dad turn and walk back to the car. And I knew that my dad was afraid. And he got in the car. And I can remember asking him questions. Why can't we go? Why won't he give us any gas? And he wasn't answering. It occurred to me as a little kid, we're in real trouble. And then the door to the place opened, and another man came out. And my dad stiffened up, and this guy got to the passenger window and said, I don't know what's wrong with that guy. I'm going to go get you some gas, okay? I remember my dad was real grateful and saying, let me give you these few dollars. And the guy was saying, no, it's okay. And I guess I felt ashamed at that moment for my dad, not because he'd done anything wrong, but because I felt like he had been made smaller in my eyes as a child. But now when I talk to people about that story, if I talk to whites about that story, they focus on the man and how kind he was. And he was kind. But at the same time, when I talk to blacks about that story, they're more focused on the fact that it wasn't illegal for him to deny us gas. That was the law of the land. And had my dad been defiant, the absolute risk was that you could be killed for speaking up for yourself. So it's the first time that I realized that there was real danger there. I was 5 years old.
Powerful story. It would be a story that clearly has stayed with you, stays with you. You see it stayed with her, and you could even hear the quiver in her voice, probably, when she began to talk about how she was feeling and when she realized that her dad was afraid. That's where I started to hear the quiver in her voice. This woman is about my age at the time she's telling this story. So here's a scenario I want to paint. Anne comes to your Maryland-based counseling office for the first time. You notice that her date of birth is 1960. Okay. She initiated counseling because of headaches and stress, irritability, and sadness since her adult daughter recently moved from Maryland to Alabama. She was referred to you by her primary care provider to help her cope with what the primary care provider believes is empty nest syndrome. Her daughter's leaving the state. Anne doesn't think to tell you about that incident. She was 5. It was one of perhaps many incidents. So you don't know about this happening. You don't know. You don't know this. Empty nest syndrome seems logical. But because you are a culturally sensitive counselor, you understand that diversity-informed practice requires an awareness of racially traumatic events. I don't believe that you can have a diversity-informed practice without providing trauma-informed care. I'll say that again. I don't believe that you can have a diversity-informed practice without trauma-informed care. So, as an absolutely brilliant counselor, you're aware that a Black person born in 1960 likely has experiences that can help you with the case conceptualization. You don't know the story. You don't know that story. You're looking at a woman who is 60, born in 1960, living in Maryland now, but has a daughter moving to Alabama. Primary care physician says, oh, why don't you get some counseling? Empty nest syndrome is really common. It happens to, so many moms, and, you can get the headaches and the anxiety, and, you can be very tearful and not know what to do with yourself. You need to figure out how to redefine your life. You need to figure out, how to maybe build a new life for yourself. All the things we say, right? Now the spotlight's on you. Now you can take care of you. And that's what we say, right? Right. Talk to me. You don't know that story. And I guarantee you, if you're working with anyone who's from a marginalized community, a racialized or otherized community, and you'll notice I don't say minority, I say minoritized. I say racialized because race is much more of a social construct, social political construct. It's how, it's how America has its caste system is built on skin color and such. And not just America, not just the United States, but around the world. Caste systems are often based on colorism. So anyway, I can guarantee you that anyone who's from such a community has a story. They got a story. They got 2 stories. They got 3 stories. They got 4 stories. They got a half dozen stories. They got a story for every year. They might have a story for every month. One of my stories, while you're thinking about Anne, one of my stories is that when I was about 6, I have 2 really good stories. I'll save one for later. This one touches on this thing. When I was about 6, maybe 7, I was walking home from school. My school was 90% white, maybe 10% Black. And this little boy named Frankie was running. And there was a stretch of the sidewalk and the route that we had to take to go home that narrowed on a bend with a huge utility pole there. And 2 people couldn't squeeze through there. Like you had to, one person, even as children, one person had to go in front of the other to squeeze through, the narrow sidewalk where the utility pole took up so much of the sidewalk. And just when I got to that utility pole, Frankie came running, and whether he brushed up against me, whether he pushed me out of the way, I don't know. He never stopped. I fell down. That's all I know, is that when he did this, down I went. So I went home. I told my mom, because I was crying. I was bruised up, banged up. I was crying. I said, Frankie knocked me down. He pushed me down. And that's all I knew was, Frankie pushed me down, whether it was with his hands, his shoulders, I don't know. And he kept going. My mom told my dad. My parents called Frankie's parents. Frankie denied anything like that happening. Frankie said, no, he didn't touch me. He didn't do anything. My dad never called me back to clarify or called me back into the room or anything to clarify. My dad put me immediately over his knee and gave me a spanking on my butt for lying. That bothered me all my life. Like, why did he not believe me? Why didn't he come back and ask for more clarity? Why didn't he believe that I had no reason to lie? Frankie, on the other hand, didn't want to get in trouble with his mom. It's only been recently that I recognized my dad was born in 1915. My dad was giving me a spanking because in his mind, I was setting myself up for danger by accusing a white boy of doing harm to me. And I carried that spanking my whole life, thinking about how unfair that was. Now I know it was protection. Unspoken. How to stay safe. Keep your mouth shut, girl. That was the message. Keep your mouth shut. Don't be telling on folk. So as an adult, I have these issues. We all got issues, right? And one day in therapy, I realized that event is one of my issues. That event is one of my issues. Had I ever told a therapist that story? No. Nope. Not until I was talking about how I don't like to feel invalidated. I get very offended when someone doesn't believe me or doesn't take my advice, or when I warn someone of something or admonish them in some way, and family member or whatever, and they disregard me. And clients, I can point something out to them and it doesn't bother me. But when someone close to me, when I point something out for safety or whatever, and they don't believe me. Too many times I've seen tragic things happen because they didn't take time to listen to what I was offering them. I was able to tie that back, doing therapy on myself, to feeling invalidated and not heard by my own father. He didn't believe me. So now I have these big emotions. These big emotions come up when my husband or my daughter or anybody says, "Oh, yeah, okay." Yeah. Every person that comes from a marginalized background or identity has those stories. You just listen to Anne's story now, but you don't know it. Remember? She's in your office. She's thinking empty nest syndrome. What's your case conceptualization? Now, let me change that. I don't want to ask that question yet. How are you going to proceed to help Anne feel safe with that story, with whatever her story is? How are you going to get there? How do you get to that? How do you get to that story? And then how do you find out if the story has anything to do with what she's feeling right now with her daughter moving to Alabama? Comments in the chat or verbally? Natalie,
Yes,
what do
we have one in the chat that says, ask her how she is doing as a Black woman in today's world. Talk about the likenesses and differences that relate to racially traumatic events in her past and in the present. Open up the discussion in order for her to tell her stories and experiences.
I like all of that.
Yes.
I like all of that. Thank you, whomever put that in there. What's powerful there is you start with how she's doing today, and then you invite a connection, anything from her past that comes up, that gets any part of her that gets activated, or if this reminds her, if what she's experiencing now reminds her of anything from days gone by.
Mm-hmm.
Excellent.
Yep. We also got a hand.
Okay.
Yeah,
Please.
that was one of my questions about, or I was thinking of was, how do we engage that racial identity and kind of when we engage that racial identity, right? Because at intake, right, we're doing a lot of the logistics, things we're seeing, right? Would it help to do like some identity mapping before we engage that, or is that something like we dive into immediately? Or is there kind of a timeline that you found works best or is most, I don't know,
Yeah, great question. I say that you broach the identity talk, so to speak, in the first session. When you introduce yourself, you talk about you invite them to say whatever they want to say about themselves, and you get more comfortable over time. I'm going to point you to the work of Dr. Norma Day, D-A-Y, and then hyphen Vines, V as in Victor, I-N-E-S. She did the seminal work years ago on broaching, and the continuum, she developed it. There's a continuum of in terms of comfort level and confidence level in broaching content about racial identity and stuff that's related to racial experiences. And the goal is to move along the continuum from, boy, I'm not sure I don't know how I would even do that. How do I bring that up? I only bring it up when the client brings it up. And she talks about the path to becoming confident in broaching. I participated in some research recently where we were looking at how people experience that, how you do that. But it starts with that, something like that introductory question. But it means starting with not just the question, but then the permission. So you say something like, I don't want it to be scripted, but the question that I used, I can start without putting a precursor, so to speak, a disclaimer on it. But if you're of a different race or ethnicity, you might say, I'm happy to work with you. And I want to be very honest and say that you have experiences as a Black person in the United States that I don't have. And if at any point in time, I am missing something that is salient to you, that's important to you, please bring it up. If I say something that is offensive to you, or if I misunderstand something, if I misinterpret something that doesn't sit well with you, please don't let my whiteness prevent you from bringing that to my attention so that we don't have a rupture unnecessarily or a rupture unintentionally. I'm very interested in how you right now, as a Black woman, are doing in our society. You doing okay? I'm not suggesting that you're not doing okay, but I'm aware that your reality and my experience will be different, or have been different. And I don't want that difference to create an awkwardness. So I'm going to put it out here right now. At any point in time, if I fail to ask how you're doing as a person of color in today's times, please know that I always care about that. I want to know. I want to know. You are not invisible here. You are not invisible. Something like that. That's a nice way to open the door. Does that help?
Yeah, absolutely. Absolutely.
Yeah. I was going to say that languaging is just really helpful to have as a guideline of how to initiate that conversation and ongoingly continue that conversation.
Yes. Now, okay, great job with thinking about how you get to know her, how you get to know her story. Now, when she tells you the story, do you make connection? Do you hear a connection? If she's telling you this story in a session, what do you hear now?
I think
what do you hear now?
Yeah, well, and for me, like helping her explore the move right from Maryland to Alabama and what that may mean for her, and with that connection to the story as well. And she's sharing, she mentioned sadness and stress and irritability, and helping her make those connections of the fears and additional fears that she may have for her daughter.
Mm-hmm. Exactly. If she tells you that story, you get to the place where you say, that sounds horrific. I can't even imagine the fear that you had.
And
Well, your daughter's saying,
yeah.
I'm sorry, go ahead.
No, I was going to say, and listening to the story as well, and thinking about from a developmental perspective, like as the adult now, that reflection of even her father, couldn't maybe do the things and the protective things that she saw her dad as being able to do. And so as mom, I know these things are a risk, and I can only do so much, and how hard that feels.
Yeah, exactly.
There's another. Oh, sorry.
No, go ahead.
There was just another thing in the chat that said she watched her dad take care of her and her siblings, and now that her daughter is leaving, she won't be there to protect her and care for her.
Pretty much the same thing that Colleen just said.
Yeah.
Yeah.
It was just I was trying to beat her as she was saying it, and I was typing it to see who could get done faster.
Yeah, that's funny. But now think about this. If you are not thinking about, okay, I've got an African-American woman here, born in 1960. I'm gonna tell you this, any Black person that was come through the 50s and the 60s, we got stories. I guarantee you we got stories. But so do the young people. The stories in the South sound a lot different than the stories, well, maybe I shouldn't say that. The stories in the South I don't even want to say it that way. Well, we got stories. I was in the North. I got spanked because I told on a white boy. I was in Pittsburgh. So I'm not even going to say the stories in the South may have been, well, I will say they were different, and they may have been met with more violence and more life-threatening situations. You can't even guarantee that. I had a cousin who was gunned down by city police in the somewhere around 1960 up there in the North. I have a good friend whose father, he was a father of four. Her father was gunned down by police in a different state. I didn't know her then. So I'm going to take that back, that Northern stories may not be as intense as Southern stories, because that may not be the case. And that's not a fair statement for me to make. So I'm not even going to say that. But I can give you another example of where I put on my hat. Now this is, Annie is fictitious. No, it's not fictitious, actually. StoryCorps, people tell their real stories. Annie is a case example that I found and I use it. Now let me tell you an example in my own practice. A woman, African-American woman about my age in a Southern state, comes in with complaints of anxiety. She works in higher ed, and in her particular, she's not an instructor, but in her particular role, there's a lot of change that goes on. And she finds that really gets to her when she starts in a direction, and then there's always these changes, always changes. So I asked her about her life, her childhood. I, just started with the questions I normally start with. Tell me about growing up and things like that. And because I knew she grew up in the South, I said, you were coming up, you were in school during desegregation of schools, integration of schools, desegregation of public places. And she said, yeah, I was. And she told me the story of being a first-year Black student in an all-white school. Her year was the year of integration. She was 9 years old. She had been in an all-Black school because the schools were segregated. Her mother was her teacher in her all-Black school. And as they called it, they would have called it either the Negro school or the colored school back in that day. Her mother was the teacher. And she knows, she knew she was really smart. Like, her mother was a good teacher, and she knew she was smart. And one reason she was afraid to go into the all-white school was because she knew she could be, good chance she could be smarter than the white kids that she was going to be in school with. And she didn't know if that was going to be safe for her. She was afraid of her own intelligence. How about that her own intelligence was going to get her in trouble with white kids, would put her at risk for violence. Not to mention the fact that there was so much resistance to integration. She knew that she could be going into a very hostile environment. And that year was the year her little sister also had to start school. Her sister was 5. So she's 9 and her sister's 5. She normally goes to school with her mom, they go in the same place. Her mom was driving her. But now she has her little sister by the hand. And on the school bus, all grades were mixed. So she's on the school bus with high school seniors, burly white football players, and, and she's 9, her sister's 5. She talked about how terrified, absolutely terrified she was. Do y'all know the name Ruby Bridges? Ruby Bridges is that little girl that you see being escorted by federal marshals into the school, the big school desegregation case. Her name is Ruby Bridges, but Ruby Bridges had federal marshals. This little girl at 9 years old was Ruby Bridges without federal marshals. And there are a lot of Ruby Bridges that didn't have federal marshals. That was the big case. That was the big case. And you see the men, these tall white men escorting her, and they have the bands, the federal marshal bands in their suits, the federal marshal bands on their sleeves. She didn't have any of that. She didn't want to change schools. She didn't want to leave her mother behind. She knew she had to take care of her sister. She didn't want to go into an environment that she knew could be hostile, where she wasn't wanted, where her intellect wasn't going to be respected. That was too much change. And when I made the correlation, when I helped her see the correlation between those events of integrating that school, change in the education system, and the changes that irritate her now in her job in higher ed, she sat back and she said, yeah, it is the same feeling. Without that information, we'd have gone through what? All the normal anxiety management techniques. I had to get to their red zone. Or else, just like Anne, I'd have been aiming my treatment at empty nest syndrome. For Anne, for her, I'd have been aiming my treatment at anxiety management. And we did have to do some anxiety management, but can you imagine how the lens shifted when we got to where we needed to get? Anybody want to talk about that?
I was just thinking too, like going off of the protection piece of seeing all of that, like I'm thinking from like the parts perspective too, of like what parts of someone's self that they had to hide to survive, what identity had to be kind of shoved down to fit in with the norm.
And really, it's like, in both of those cases, it would be everything. It would be like everything about me. My intellect, but I give her and her mom credit for this. She refused to shrink. She refused to shrink in that way. Going into that new school, she refused. And there were kids that didn't like it. But she told me, she said, no, she said, I was smarter. She said, I was smarter. I did learn easier. But she said she held her head up and she didn't allow herself to shrink. But the anxiety was still there. It didn't remove the anxiety.
And yes. I can't help but wonder too about, similar to what Natalie's saying, of like just that kind of hiding and forced, shrinkage, like also like minimizing the experiences that they've had, and you through exploring these with them, almost that permission giving of connecting with that was an incredibly difficult thing that has stuck with you, that is valid, and being able to help make those connections and bring to life what they have experienced.
Exactly. Thank you for that. The connections. I'm doing a webinar on this Saturday for my own business. It's open to professionals. If you're interested, put it in the chat and I'll send you the link. But I'm talking about the fact that we've been taught that rapport has to be the foundation of a strong therapeutic bond and relationship. That's the starting point of counseling. And I'm suggesting that cultural context is a starting point. And from cultural context, you can build rapport. And if you heard the example I gave when Braden asked the question, the example I gave, I used cultural context to build rapport. Doing a whole training on that. Cultural context first to get to rapport. Why? Because when people have been racialized and judged for their identity, first thing they want to know is this a safe space for my race? And just because I'm Black, if I'm working with a Black woman, just because I'm a woman, just because I'm a Black woman doesn't mean it's a safe space. Doesn't mean that. I still need to make that known. I need to make that known. I've had Black people tell me they've never been impacted by racism. I don't want to invalidate someone else's view of their life, but that tells me that what they don't understand is institutional racism and systemic racism. So no one has called you out your name. They've not used certain derogatory words when speaking to you. They've not been outwardly, openly disrespectful. But if you ever had a neighbor of another color say, even if you even heard, it didn't have to be your neighbor. If you've ever heard a person say, yeah, the neighborhood was starting to change and we just really wanted to move to a better neighborhood. That's become so normative in the United States that what no one hears except perhaps the Black person in the room is that the neighborhood was demographically changing. And you weren't comfortable with that. So you wanted to go to they wanted to go to a better neighborhood. Or when you make reference to a part of town as being, oh, that's not a good part of town. Go around, drive around the other way, take the highway. Don't take the surface roads. That's not a good neighborhood. What makes it not good? The people, the poverty, the way people survive, the anger of the people being marginalized. What makes it not good? Just got a gnat or mosquito flying around here. What makes it not a good neighborhood? Maybe I enjoy my neighbors. And you got as much crime over there as we got over here. It's just a different kind of crime. Who hears that as a microaggression? Who's not, if you're not thinking about redlining and gerrymandering, then you say, I've never been affected by racism. But if you understand redlining with the mortgages and gerrymandering with the voting districts, you know you've been affected by racism. I'm glad that no one's physically assaulted you. I'm glad that no one has ever called you out of your name, derogatory term. No one's ever spit on you or beat you up because of your race. But when I hear people say, I've never been affected by racism, that tells me that they're only thinking about the interpersonal racism and not about the institutional and systemic racism. I don't recall the question that made me get on that path. What was it?
I'm not sure
Whatever.
either, but I'm glad we went there. Yeah, it was an important path.
I hope it helped. Oh, I know what I was saying. I have to communicate that it's safe. The point was that just because I'm Black doesn't mean it's safe. Because when I asked that person, it was a work colleague, how she was doing. This is around the time of George Floyd, how she was doing, everything. She said, I've never been affected by racism. So she said, I worry about my husband and my son because they're darker complected than I am, but I've never been affected by racism. And I was stunned. I don't think I'd ever heard anyone, a Black person, say that. I was stunned, and I had to stay in the moment there with the conversation because my mind was going 100 miles an hour in different directions. So that's why even I, as a Black person, bring that up. I don't assume safety. I don't assume safety. I don't expect them to assume safety. So that's why I bring that up, because they may, you know, they might have encountered someone who's Black for whom it wasn't safe, someone who invalidated their experience. And, you know, I've had people say, oh, Ma, I talked to my other Black friend and she didn't see this whole situation as a problem. Microaggression, like, you're a Black person that doesn't, maybe you're overly sensitive. Maybe you're not, like, you know, other Black people don't see, all Black people don't see it this way. It's like, okay, that's fine. That's fine. But yeah, my other Black friend, yeah, that was a microaggression too. I'd have to say that. Yeah. So safety, rapport, that's how you get there. Comments, questions on that whole first section? Talk to me.
I was gonna say, like, that connections and the safety, like, I wrote a note about that because I literally just had an experience yesterday with a client of, like, building the safety and then the connections came afterwards. And how there was a lot of just things that I was saying, the notes at the beginning of how to bridge that gap and how to start those conversations is so important, because once I did start asking the deeper questions instead of surface level, I realized it was much deeper. And when I was able to ask those questions, she got this safety. And afterwards, like, I even asked her experience with it, and she even mentioned, like, I just didn't know if you would understand my experience, you know. And so I think it was just a great conversation and a great learning experience for me to also go into that conversation of almost like, hey, now I want you to be open of if I'm not understanding something, or if there is something that, like, my lived experience is not your lived experience, like, let me know, because this is your time. Like, I want this to be valuable to you, not just me saying whatever that I think is going to help when it's completely missing the mark.
Yeah, I so respect that you put it out there that way. That's so important. And not everyone is at the point developmentally where they feel like they could say that. I'm so glad that you did. It's important. Thank you for sharing. Let me move on here. I want to talk briefly about just some general diagnostic disparities that we see, the research shows, by race and gender. And as I go through these, think about whether or not these disparities, or what is believed to be at the root of the disparity, with the bias or the stereotype or whatever. Think about it, whether you've ever seen it or maybe even experienced it. These are just some examples. Diagnostic bias and over and under representation. Underdiagnosis of eating disorders for Black women. I'm going to go through each of these. I'm just listing them here. This is the part where I tell you what I'm going to tell you. The overdiagnosis of disabilities for Black school-age boys. The underdiagnosis of autism spectrum disorders for Black children. The overdiagnosis of schizophrenia for Black men. The underdiagnosis of depression for Black men. Let me start with the eating disorders. Black women experience marginalization, stigma in a lot of ways, but we don't often think about eating disorders. Clinicians tend to assume that Black women are somewhat larger than white women, that Black women actually prefer being bigger, and that they do not face pressure to be slender. This creates the false impression that Black women do not develop eating disorders. So with those assumptions, when a Black woman does develop an eating disorder, counselors don't catch it. They fail to get it. So you have this inaccurate diagnosis. What Black women tend to get is adjustment disorder. So bottom line is that our objectivity as clinicians can be impeded by race-based stereotypes. That a Black woman isn't bothered by her weight. And that delay in the diagnosis just makes the eating disorder continue to worsen, gets more severe. So early intervention, back that up. Recognition and early intervention will help for long-term recovery and prevention of life-threatening consequences. You just don't think of a Black woman when you think eating disorder. You think of a young person, a white person, a very thin person, female. And men develop eating disorders too. But you think of a young, thin, white, female, for some reason, when you think eating disorders. I own that. I have to watch that. Anybody else agree with me there? Is there anybody else who would say, yeah, I think I probably have that same or similar image? Anybody?
Yeah.
Mm-hmm.
Mm-hmm.
It's believed that the culture, the values, the dietary culture, like I guess I could say dietary culture, but it's believed that those things, that with those things in Black culture, Black space, whatever, eating disorders don't develop. I believe a lot of what you see in Black women does have to do with eating disorders that are undiagnosed, that are overlooked, ignored, because it doesn't even come up on the radar. It's a possibility. Go ahead.
I was just thinking, like, even in other trainings and the literature and advertising is the wrong word, right? But all of the media about them, like, just racking my brain for when have I seen any examples or indications or storylines of Black women, women or men with eating disorders. And I can't think of any.
Exactly.
Mm-hmm.
Exactly. I think that let me say this. There's just this expectation. That's what I'm going to say. There's an expectation that Black women are larger or will be larger than white women, probably based on some genetic features around muscle mass, curvature, all kinds of things. Yeah, curves vary by genetics. And you just got to know your biases. You just got to know what and a bias is not necessarily, here's the thing. Yeah, there are positive bias and there's negative bias, but there's also this middle ground that we don't talk about, which is like an expectation bias. You expect something, so therefore you're biased in what you see, and that's huge. That's huge. You got the overdiagnosis of disabilities in Black school-age boys. Again, sometimes based on expectation, what you expect to see. In my book, I talk a lot about how after Reconstruction, stories, media participated in the negative caricature and discriminatory kind of roles and stereotyping that became prevalent in literature, which is Black as dangerous. And that was necessary because after slaves were emancipated, the general culture still needed some way to maintain the hierarchy. So they amped up the image of Black as dangerous and Black as less intelligent. So when Black children are seen, the less intelligent and danger image, it even shows up in how kids are treated in schools at a very young age. Students receiving special education are likely to identify as African American, male, urban, and from marginalized socioeconomic spaces. Black students make up, right, as of this study, it's just a couple years ago now, but 17% of the nation's general student body, but 33% of the nation's high incidence disability categories. I'm going to show you how I don't believe that's, no, I believe what it is what it's portrayed to be. Black students have greater rates of reported emotional disturbance, cognitive disorders, learning disabilities, and speech and language disorders. In other words, almost everything about Black boys is pathologized. That's scary, but that's true. Civil rights data collection reported that Black males make up 16.6%, that's close to 17, special education students, while they comprise only 8.5% of the total K through 12 student population. A good friend of mine, a colleague, did his dissertation on the role of school counselors in the overrepresentation of Black boys in special education, and found that the school counselors were feeling almost coerced or pushed, I should say, into making those placements because teachers don't know how to communicate. They are categorizing behaviors as problematic. They don't know what to do, and they send the referral to the office for special education. And some of these kids don't need special education. Here's a case study, Malik. He's 8 years old, African-American. His father's an attorney. His mother's a corporate executive. He has one 5-year-old little sister. He is in 2nd grade at an elite private preparatory academy in a major city. He has a counselor who is an African-American man. Play therapy, it's a private practice. While he is in a racially marginalized category, he is economically equalized, economically privileged. He gets regular pediatric visits and is a healthy male child with healthy 8-year-old boy energy for the most part. His parents report, it's why they put him in counseling, impulse control difficulties, poor emotional regulation. Now, granted, he's 8, but even for 8, they recognized his emotional reactivity is not age appropriate. He is, maybe we should, see what's going on here. Struggle with transitions. Academically, he's above grade level with his reading. His math reasoning is advanced. His vocabulary is amazing. Very bright. very bright. But then you got this impulse control and the emotional reactivity going on. What are your first thoughts? What's the likely diagnostic path for Malik? What's the typical case conceptualization? Commonly in treatment plans, what do you have? Think about barriers, marginalization, but do your standard theoretical framing and give me some ideas. Where's this usually go?
I mean, I would say typically if we're looking, especially with the school's consideration, right, and looking at that impulsivity and or direction following, are we assessing typically for an ADHD or some sort of behavioral diagnosis?
That's someone chiming in. I don't want to cut anybody off. Okay. Yeah. ADHD. The counselor said, let's work on some other things before we start talking about personality disorder developing. And
what are you doing?
There was thought about whether he's on the spectrum because of the emotional dysregulation, contrasted with the superior intellect. There was that thought. So yeah, those are diagnostic paths that would be pretty common with the standard theoretical framing, the typical conceptualization. But now let's put some other things in view. Oppositional conduct, ADHD, autism spectrum, you said all that, okay. Let's put some other things into perspective. In the back of my mind, I was aware, so I'm talking to mom. The kid has his own therapist, his own play therapist. I don't do kids. Kids scare me. But here's what I know about Black women and their maternal experience. Greater pregnancy complications, higher maternal morbidity, higher preterm birth rates across income levels. Socioeconomic status does not eliminate medical racism in OBGYN medicine or any medicine. We've put a lot of attention over the past few years on maternal mental health, medical racism in that space, because so many Black women die or lose their child in childbirth. It's disproportionate. The number of preterm births, really, really disproportionate. I began to think about that. He's 8, second grade, so second year of school. It's probably been going on for a couple of years before they put, suggested him, let's put him in counseling, thinking he's, at 6 or 5, 4, 5, 6, 7, you think they're going to grow out of it. Getting ready to turn 8, you think maybe something else is going on here. I'm listening, I'm thinking. I remembered that mom went into labor early. Oh, what's the significance of that? Anybody know? I'm gonna bounce over this. Time to cover that. Anybody know the significance of preterm births? Preterm birth is associated with difficulty with emotional regulation, difficulty with changing tasks, and difficulty with impulse control. Preterm births. High incidence of that. Anybody want to take a guess as to why?
They're not fully developed.
Bingo. This mom went into labor at, what'd she say? Her water broke at 29 weeks. It was so early, she didn't even know her water had broke. She wasn't feeling well and thought, it's been going on for about 24 hours now. Let me go to the doctor. Doctor said, sweetheart, your water broke. You're going straight to the hospital right now. And we're going to try to keep this baby in you. She wasn't having contractions yet. So at 29 weeks, she's in the hospital on hospital bed rest, like do not move. The fluid in the sac has the ability to replenish itself, but mom has to be on bed rest to ensure, to give this kid the best chance at going closer, at least, to full term. She delivered at 32 weeks, so he was still 8 weeks early. I believe the recorded birth weight was 4 pounds 4 ounces. Not too bad. He was in NICU, and they were, they always talk about the lungs. They need the lungs to develop because obviously breathing, right? But the other organ that is undergoing significant changes in those last 8 weeks is the brain. The brain. And the parts of the brain, not going to make it a science class, but the parts of the brain where the neural pathways prepare to master and learn these things, that's the part of the brain. It's one of the last areas to develop. And that's what should be developing in utero. When a child is premature, born preterm, then the brain tries to continue to do that. But now brain activity it's trying to manage all of the life stuff outside the womb that the brain shouldn't be having to process. The brain, the work in utero is to develop this brain, right? To get it ready. And suddenly that slows down because now the brain is responding to all these things, all these life, stimuli, like outside the womb. This is relatively new research. And I believe that's the case because you'd have to do some longitudinal studies to see what happens. And what they found is that the problems show up between the ages of 6 and 9. Why between 6 and 9? Because that's first grade to third grade, when more is expected behaviorally. You're expected to have more control and to make transitions and the emotional regulation and those kinds of things. All that's expected. But the brain is not neurodivergent, as in ADHD or ASD. It's not that the brain is biologically made different. And that's what you have when you have ASD. It's a different brain. They're wired differently. ADHD, wired differently. This is not about being divergent. This is neurodevelopmental, meaning that the brain is trying to catch up with what couldn't be done developmentally in the womb, in utero. And what do we do? Without that knowledge that preterm birth. So when I couldn't wait to get to mom when the light bulb came on. I couldn't wait to get to mom and say, does this counselor know that he was born preterm? And she said, no. And I said, tell him that. Make sure he knows that. And if he doesn't understand why you're saying that, tell him to, look up the topic, do the research, find it, because it's out there. It's out there. And what are we doing? We talk about the school to prison pipeline. We say that starts in about like 3rd, 4th grade, because by that time teachers have labeled African-American boys as whatever, with all the, all the stuff we already talked about, oppositional, defiant, behavioral, all that stuff. And Black women are having more preterm births than any other demographic. But how many of their children are actually having the neurodevelopmental aspects of preterm birth addressed? Man, you better know I got on that thing. I'm telling it on the mountain. I'm telling everybody I know that preterm birth you must ask those questions. You must ask those questions. And think about Black men. Think about the moms, the parents that come in. Think about the teachers. Think about the legal system. Think of the medical system. Think about all the systems that need to understand this. OBGYNs, they probably don't even recognize that, because their job is just to get the baby out and to make sure that, that it's functioning as an infant ought to function, breathing, the lungs, etc. So think about the obstetrics, think about pediatricians, think about early childhood development workers, think about school teachers, think about counselors, school guidance counselors, right? Think about law enforcement. How many Black men are in jail because they had a problem with emotional regulation or impulse control? I would love to know how many of the disproportionately incarcerated Black men were preterm births. That's just me. I don't have research I don't know the longitudinal research to prove that there's a correlation there. So I put that out there. I am not putting that out there as fact. I'm putting it out there as a question. And I'm looking for some researchers to help me get the answers. But in the meantime, it's a question. And in the meantime, the question for us as providers is, Mom, did you carry to full term with your pregnancies? Does that not change everything? Does that not change the target? Because if it's neurodevelopmental versus neurodivergent, you're teaching different skills. You have different expectations. When it's neurodevelopmental, you can start in the very early preschool years with things that help. And even if it's a preterm birth, we could start in infancy with the kinds of tools and play that will help those neural pathways catch up and develop in a timely manner. With neurodivergence, you teach people how to live and live with and accept the fact that they're wired differently. So you give them skills to manage or compensate or understand or ask for what they need, etc. With neurodevelopmental, as opposed to neurodivergence, with neurodevelopmental issues, you would intervene, and if you know this, you would intervene with things that give them a healthier start, teaching them co-regulation skills, teaching them to, as the one article I read said, you teach them that sometimes their body will get ahead of their brain and that it's not their fault. And what I have found is that with good parenting, The children who are struggling from a neurodevelopmental standpoint will come back when their brain catches up to their body and say, Mommy, I'm sorry. I shouldn't have done that. I was something, and they're able to like look back and say, oh, I shouldn't have done that, when they understand that their bodies get ahead of their brain. It's fascinating. And only when we begin to, without exception, when working with people of color, ask about the preterm births, will we be able to get the right diagnosis and start to aim our treatment at the right target? Thoughts or questions?
Yeah, I just put it in the chat to answer it now, but I'm getting a little fired up over because I can't help but think about Bruce Perry's neurodevelopmental model of therapeutics as well, that tells us that the best way to address some of those neurodevelopmental missing building blocks are before age 11. And so thinking of these boys and these young children who these questions aren't getting asked and they're written off as bad behaviors or defiance. And not that work can't be done after that, but just that key and crucial window is so greatly missed.
Yep. And teachers, like we learn a little bit of the neurodevelopmental stuff in counseling. Psychologists get more of it. Psychiatrists get some too as well. Counselors don't get a lot of that. Maybe school counselors more than community counseling majors and things like that. But we don't get a lot of that. We've already taken our break. We don't get a lot of that. So we go with the DSM stuff. And the teachers go with the learning disability stuff. We all go down our lane, the lane that we were trained in, and this is overarching. We gotta do better. We just gotta do better. Thank you for saying that.
Well, it also makes me wonder too, like infants who are born preterm also have the higher, it's a very common experience for them to get brain bleeds. And it's like, even though it's minor, they heal on their own. And I think that's something to think about too, is like, even though that's something minor, that's not something the brain should have to go through. And that is so important of like, how could that affect future like emotional, mental development too?
Yes. Wow. I didn't know about the brain bleeds. I'm going like, oh, wow. Yeah, I didn't know that. Thank you for sharing that. That's a diagnostic miss that's not necessary if we know. It's a diagnostic miss that can change the trajectory of someone's life. Oh my gosh. So, with the literature that I gave that Malik's mom, I made up his name, but with the literature I gave Malik's mom, when I checked in, we checked in last week, I said, how are things going? She said, he's doing much better, because now she has tools. And she was already doing some good things. She already understood, either intuitively or she's a reader. She already understood the co-regulation. So she was already doing that. And she was already doing a couple other things. But now she can get the rest of the house on board, the dad and whatnot. And she can do some other things as well to help. And she already told me, it's only been like 2 months. She already told me he's doing better. He's doing better. I'm going to shift to Black men, schizophrenia and depression. Long story short, in the interest of time, you all know what schizophrenia is. For the diagnosis, the symptoms must not be explainable through any other mental health disorder like a mood disorder. But yet, despite that, Black people, or especially men, are substantially more likely than whites to be diagnosed with schizophrenia, even when a mood disorder is present. Mental Health America found that clinicians tend to overemphasize the relevance of the psychotic symptoms and overlook the symptoms of major depression when they're treating Black clients. especially men. Black men are 4 times more likely to be diagnosed with schizophrenia than a white man. Meanwhile, depression is underdiagnosed. Clinicians could be, if they're maintaining their objectivity and not overdiagnosing, would give a diagnosis of depression with psychotic features if they pay attention to the depressive symptoms. But in Black men, they tend to focus on the psychoticism, and like the depression just kind of, I don't know, it just gets sidelined, it gets marginalized. This study that, I really love this study, suggests that our current depression scales are not capturing the full range of what Black men identify in depression. So we're omitting these cultural nuances that could explain why there's a low prevalence of depression recorded in Black men. But yet, in recent years, there's been increased suicidal ideation and completions with Black men. The rates for suicide, that's one of the reasons I got into, overlooked is in part because I lost a first-degree relative to suicide. And that's when that was part of my recognition that, wait a minute. What's going on here? Hence, overlooked the unspoken issues in Black American life, the unknown issues, the invisibility, the invalidation. This is the study I love, 2021. What they did was they looked at, I'm going to try to make this brief, but this is really powerful, so I don't want to totally skip over it. They looked at how Black men describe the experience and found that the language is very different because they measure the experience in more concrete, culturally specific ways, right? I'm assuming that you all know the symptom criteria for depression, so I'm not going to spend time on that. That's what that slide is. You know that you have to have 1 or 2 with a total of 5 out of all these, out of this symptom list. So here's what they did. They did a cluster map, which I guess that would be grounded theory research, I believe. But they developed a cluster map of Black men's depression characteristics. They listened to what they said. They listened to their family members and their primary care physicians and came up with these 6 clusters, categorizations of how expression of how depression is experienced and expressed. And it doesn't 100% match in language, at least, our major depression scales and screeners. So the categories are social pressures, diminished drive, physical states, emotional states, internal conflict, and communication with others. I need you to see this. Physical states. They recognize when the blood pressure goes up. Self-harm, suicidal behavior, binge eating, insomnia, oversleeping, sleeping frequently, heart palpitations, weight loss, weight gain. Somatic symptoms and clinical diagnoses here. Diminished drive. Diminished drive is like unfinished business and untapped potential. When family members notice untidy or messy appearance in their home, and a good one is in the car, because as An untidy home is to a woman as an untidy car is to a man. It's something that can be an indication that their energy is not where it usually is. Not being able to complete tasks, feeling like they're not able to provide for their family. This is huge. This next one is huge too. Not being able to complete life goals, finishing school, getting a job, traveling, etc. And of course, excessive substance use. But not having the drive and the energy, not feeling like they're able to make progress in society, to make progress with their goals, losing the drive to do that. Along with that comes social pressures, not being able to keep up appearances with their clothes, their shoes, etc., in the same way that they see other Black men, their peers. Fear of unknown consequences of today's political environment. Adherence to norms of competition, like this, I got to do better than the other guy. I can't be behind. Adherence to cultural norms of success and power. I see this, I've seen this. There's a term called Black excellence that I don't particularly like to use, but it's a popular term right now. And I know men who are all depressed, sitting there with corporate jobs and many measures of success, who are striving for this thing called Black excellence that they feel like they still have not yet attained. Like there's this sense of like there's still something missing. There's more success. The constant strain to do what you have to do to survive, to get ahead. I know I was talking to a mom whose her boys went to be with their dad and their stepmom for the weekend, and dad had to work, and dad came home crying. He came home from work crying because he said, I got to work all these jobs to make my child support, that when my kids are here, I can't even be with them. I can't even spend time with them because of what it takes to support them. Social pressures, lack of work-life balance. That's what that was. Ignoring physical symptoms, excessive engagement in activities that improve outward appearance, over-exercising, overspending, needing to measure up thing is huge. When they don't feel like they're measuring up. The last one is interesting. Increased attendance at religious institutions. That's one of those inverted ones, because it's not that the attendance at the religious institutions causes the problem, but when they're feeling low, that tends to be one of their remedial activities. That can be one of the healthy things that they do, but they're going to church more when they feel bad because they're looking for strength. They're looking for something to give them some comfort and some encouragement and some hope, some faith to believe that things will get better. Communication with others. Unable to communicate properly, isolation, having unclear or limited communication. Delaying and ignoring emails and calls and texts, isolating, speaking in a discouraging way to others, the whole, misery loves company kind of thing, being unclear or limited in what they communicate, feeling hopeless because of what they're exposed to. They don't even know what to say. They don't know what to say or what to do. They don't know how to communicate that feeling of hopelessness that comes from the prolonged exposure to the violence that they see. I mean, how many times have we seen the knee in the neck with George Floyd? I don't know about you, but when the name George Floyd comes up for me, that's the image I see. That's the image I see. Really don't even see George Floyd's face when you mention his name. I see the knee and the neck image in the street, the news coverage, the exposure, all those things. Communication coming up as blunted or flat in affect, not crying, no facial expression that communicates anything, withdrawing from activities, their hobbies, their interests, not being able to maintain romantic relationships, stuffing their emotions, ignoring when other people try to give support, personality or mood changes, even with their significant other, romantic relationships, and volatility in their moods and behavior toward others. Using indirect forms to communicate what they feel, writing long emotional status updates on social media, letters, emails, etc. Blaming others for issues. Only reflecting and reminiscing on certain life stages, those life stages that they feel were better or that were problematic, but just like not being able to stay in the present. Changes in their sexual behavior, like losing interest, becoming perhaps more aggressive, and then going back and reestablishing old relationships, going back to romantic partners and friends from the past, and then looking for closure, trying to wrap up loose ends. We all know that is always an indication of a person's emotional state and suicidal ideation. The emotional states include both internalizing and externalizing, not able to get up and go, lack of motivation, anger, feeling sick, low self-esteem, being stagnant, feeling stuck in life, feeling lazy or being lazy, as we might call it, but feeling out of control, feeling irritated or agitated, feeling fatigued, hopeless, frustrated, crying spells, not feeling like yourself, worry and anxiety. These are the ways that Black men describe this. Okay, so just keep that in mind, and then you'll see where this goes relative to our instruments. And the internal conflict. This has, for Black men, a direct correlation to how they feel about their standing in the Black community. You see, this issue, this sense of belonging and measuring up, it keeps coming up. Belonging and measuring up. So internally, when they have this pessimistic outlook or this negative mindset about themselves, when they feel guilty about whatever, like the things like not completing tasks, the unfinished business, those kinds of things, feeling unqualified, imposter syndrome, heightened sense of fear, dread, not feeling supported by the Black community, not feeling supported by their own. There's that competition I mentioned where they want to, they want to measure up, want to feel supported, but don't feel safe because they don't want to be seen as weak, not feeling valued for their work, not seeing the benefits of hard work over time. Sometimes just feeling like things are off. Sometimes they're feeling attacked. They recognize they're responding with defensiveness. And as they age, change in their mood, change in their ability to be hopeful. The aging process can take a real toll on anybody, especially men, but especially Black men. And then this numbness, the melancholy, the lack of engagement that can be observed. Some of the people, the relatives, the family members who participated said, there's just no joy in his eyes. Those are the 6 clusters. Let's look at this. The says D, if you want to see across the top, these are the clusters that were identified in the research. Physical states, emotional states, internal conflict, communication with others, social pressures, and diminished drive. What does the says D capture? Physical states, yes. Emotional states, yes. Internal conflict, no. Communication with others, yes. Social pressures, no. Diminished drive, yes. 20 items, we're capturing 4 out of 6 categories with the says D. The PHQ-9, what are we capturing? Physical states, yes. Emotional states, yes. internal conflict, communication with others, and social pressures that Black men describe and feel as when they speak about their experience with depression. We don't capture that with the PHQ-9. Diminished drive, yes. The back, the BDI, doesn't capture communication with others, doesn't capture social pressures in 21 questions. Those social pressures all primarily had to do with life in Black communities or measuring up as a Black man, what it means to be a Black man, success, etc. Communication, internal conflict, same kinds of things going on there. So we do not yet have an instrument that uses the language that a Black man uses that would help us to identify depression. And I personally think that one of the reasons for the schizophrenia diagnosis as opposed to depression, even if there are psychotic features, is that the sense of not feeling safe can be mistaken for paranoia. The feeling that someone is, if you ask, have you ever felt like someone was, I can't think of how it's actually worded, watching you, stalking you, whatever that particular question is. Black man says, yeah, that's not paranoia. That's because he knows what it is to be profiled in the store. He knows racial profiling when he sees it. He knows when he's being watched. So yeah, he doesn't know that's a depression question. He's saying yes to his real reality. Yeah. Yeah, I do feel like someone's out to get me. I do, because I get nervous when I see a police car. I had a family member who had a tail light out. And as soon as his wife recognized it, and she told me, she said, yeah, well, he doesn't have time. He's busy doing this and that and the other with work. And she said, well, I got to get that car in there to get that tail light fixed because I know he'll get pulled over sooner than anybody else. So the whole thing was, loan him a car for the day, do whatever we got to do, right? Get the tail light fixed, get the tail light fixed. That was a threat. Like that's unsafe behavior. It's like my dad turning me over his knees just so I didn't get, so I wouldn't put myself in a position because I broke a rule, you know? What are your thoughts? Let me pause, take a sip of my coffee, ask for your thoughts.
I was going to say just some of the stuff that is missing from a lot of these scales are almost some of the most important factors that we should be looking into and exploring.
Yes. Thank you so much for saying that. Yeah. Yeah. And again, invisibility, not things that you would think about if you are not a Black man. If those, if life looks different for you, think about asking these things. And you're right. Some of the most important things, how do you feel you're doing in terms of your standing in the Black community? How do you feel about being a Black man in a white society? How do you feel about being a Black man in amongst your own community, your own culture?
And I think, like you mentioned, not only asking, but knowing how to ask to get to the intentionality of the question, because like you said, there's so many things that it's like, well, on the surface, like, no, like that thing doesn't fit for me, or that diagnostic question or assessment question. But when we're really looking at what that means in their lives, the application of that becomes our responsibility to ask that.
Yes. That's the whole moral of the story. Thank you for saying it. That's the moral of the story. We have to be attuned. And this research, here we go. It's Leslie Adams et al., a 2021 study on refining Black men's depression measurement, concept mapping study. If you're able to look that up, get that study and read it. I don't know. My first response to all this stuff I find is, oh, I need someone to do the research. They might be already in, I don't know, they may already be in the process of trying to put together trying to develop an instrument. Of course, that takes time because it's got to be normed. The reliability, the validity, all that stuff, has to be measured and all that. But I certainly hope that they are in the process of creating an instrument. And if they are not, if I find out that they're not, if that's not part of their plan, you better believe I certainly am going to be asking if they'd be willing to help someone else do it. Like, share the results, the nuances, and be supportive for someone else that might want to do it. I don't do original research. I feel like my calling and my job is to bring the research, take the research take the findings from research into practice. My job is to find this stuff out and give it to you all so you can apply it. That's where I get my kicks. The research itself doing it doesn't impress me. Finding it and applying it, that feeds my soul. So bottom line is that the depressive symptoms in Black men can be stated in ways that are not consistent with the DSM language. And sometimes because of just the prevailing masculine expectations. There are some things that you're going to say, no, I don't experience that, but they would talk about it in other ways. So we got to be thinking about that. And that the fact that these current depression scales may not be capturing the full range of the experience could explain that low prevalence of depression and the increasing rates of suicide loss when you're just using existing instruments. The implications here that counselors and pastors and concerned persons in the community need to be paying special attention to how Black men talk about life and the social and emotional strain that they are under. Doctors, primary care physicians especially, and pastors, they're the ones that are likely to hear these kinds of life complaints first. So we want to teach, we want to provide opportunities for pastors, especially in Black faith communities, pastors and other religious leaders, to recognize what they're hearing and not take a spiritual bypass on that. Include the things that a person finds spiritually uplifting, things that give them hope and things that give them, boost their faith or their belief system and their tenacity and their stick-to-itiveness and all of that. But in my practice, I sometimes it's the integration that makes sense. The integration and the psychoeducation that helps people separate. And I'll say this too, real quick, helps people separate the mind from the brain. I'm always telling people the brain is an organ. You can perform surgery on it. The brain is like any other organ, can lose some sense of balance and functioning because of stress or because of anything, right? Black culture often conflates mental health and spiritual health and treats mental health as if it's a spiritual health problem. And I sometimes have to help people distinguish normal anxiety of, worry and concern and fears that we all have, and make that distinction from generalized anxiety disorder. Because people will tell me, give me a scripture that says they shouldn't be anxious. And I'll say, well, I think that scripture is encouraging you to have peace in the things in life where you would have cause for worry. Generalized anxiety disorder is free floating and attaches itself to everything. You have generalized anxiety disorder. If you quote that scripture, the person's going to feel like they have failed. I do a lot of psychoeducation to help people make those distinctions. And when I say the brain is an organ, as much as we know that, people tend to go, huh, it is. Oh, yeah. Okay. And I'll explain that the mind is a very abstract concept. The mind is more about how you make sense of life and the world. And that's abstract. That's a very complex, convoluted system of thinking. But it's not the organ that does the thinking. Anyway. Primary care settings, really important because they are the most accessible point of care for many Black men. And a lot of times it's missed because a lot of Black men don't even want to go to doctors. There's so much medical mistrust because, unfortunately, the medical community has not gained, or in some cases regained, the trust of Black and brown people. Just not there. So what can counselors do to improve information about the experiences, information about the experiences of Black men? Let's discuss it.
I was going to say, like, that intentionality with our questioning, remaining curious, really focusing on what their experience actually is rather than what we view the experience as.
Yes, you nailed it. The lived realities. The lived realities.
Maybe doing like research beforehand too, like doing the research to know what questions to ask. So like maybe understanding kind of all sorts of clientele, but knowing, if you're going to be meeting with somebody, kind of going back and looking at, okay, well, what might they have been going through when they were younger? Because I wouldn't have known some of the things that you knew to ask, about segregation and stuff like that. In my generation, I wouldn't have known to ask that.
Yeah.
But I could, because I could have done research. So
yeah. And I don't want to politicize this, but knowing history is important. Knowing history is important. And if we allow historical erasure, how will we really know how to help people who have been impacted differently by history? That's important. Everyone's not impacted by history the same way. And we know that trauma is carried, transmitted intergenerationally. There's a study that shows, they looked at, they did medical studies. So it's fascinating. They did medical studies on descendants of Holocaust survivors, 3 and 4 generations later. Okay, so the Holocaust, 1930s, 1940s, right? 3 and 4 generations later, do you know that compared to their peers, the descendants of Holocaust survivors still had altered stress hormone profiles? Yeah.
So just to, I'm sure LaVerne, but it's so, even going back to the discussion about like asking the questions about premature births and things like that and the things that we experience, I think the most fascinating part about epigenetics for me is the fact that my potential descendants, I am a mom of 2 girls, and any children that they may have as adults have been inside me because they're reproductive.
Exactly.
Trauma that I experienced potentially before, during my pregnancies with them is impacting those future generations, and thinking about those lived experiences.
Exactly. Exactly. So I am carrying the residual effects of what my enslaved ancestors endured. In fact, each generation, epigenetics, each generation, it becomes wired to survive the experiences of the previous generation. It's assumed that these certain markers will be necessary. And whenever you're in trauma, right? You know what happens with blood pressure, heart. You know what happens with insulin production. Everything. Your body is always ready for fight or flight. So, and when you're in fight or flight mode, all those systems are on high alert. Brain's on high alert, looking for threats. The body is highly activated to be able to either run or fight or etc. Anxiety and all the things, right? Because the heart knows it's always got to be ready. Your circulatory system always got to be ready. Digestion gets slowed down because we don't need to sit and eat berries if we have to fight. We don't need to go to the bathroom if we have to run. And then we wonder why African Americans have higher biological expressions of hypertension, diabetes, heart disease, and cancer. I'll tell you why. Because I'm inherited a genetic predisposition for those states to be active. The bodily system stressors that was the trunk of the tree. After you deal with the red zone, the trunk of the tree that's where the core bodily functions are represented, and the diagnoses come whenever there's offshoots of that manifest in the behavior, and that's the leaves and the fruit. So we need to ask some ancestral things too. One of my podcasts, our podcast is called The Multicultural Mindset. It's on YouTube. I interviewed a woman who learned of some of the violence against her family. It kind of resulted in a whole massacre, family dispersion thing. And when she found out what had happened in their lineage, it explained for her so many family behaviors and patterns and trends. It gave her so much clarity as to why family interactions are as they are. But without that knowledge, she wouldn't have known that. And how do we find that out? She was able to find out for her own family. Many families are not. But it's incumbent upon us to ask people what they can tell us. Whatever they can tell us. This is something that I like to use. It's my revision of other kind of race narratives that I believe it has the what, the how, and the why. It gets to a lot of things. It is essentially another form of psychosocial history, but it's asking your ethnocultural experiences. Now, people say, do you just go through every question here like this? Not usually, because it can be too much. It can be too heavy. But I keep these questions in mind, and I ask them when I feel the instinctive prompting, so to speak, to do that. The race-based narrative is essentially your story, your set of stories that enforce or reinforce your expectations of life. Your race narrative is produced by what has happened to you, the people who have been involved in your life, the situations, the experiences, positive or negative. The racial narrative, again, the sum total of all of the stories of your life that intersect. So the story about getting a spanking because it was assumed that, I lied about what a white boy did. The time when I asked my mother why the monogram on my towel, which had my name on it, written very nicely and exactly as she had taught me to write it, capital L, small a, capital V-E-R-N-E. It was a nice monogrammed embroidered towel, but it had a little white girl on it. And when I asked why the little girl on the towel didn't look like me at the age of, whatever I was, 6, 7, whatever. And my mother said, they don't make things like that for us. Well, 60 years later, I remember that story and I still have that towel. I kept that towel because of I just like the towel. As an adult, I look at that towel and I think about what it represents. Those are my stories, my race narrative stories. When, as a teenager, one of my classmates who happened to be a white guy said, hey, you know what, we're always at the games and stuff. Why don't we maybe, grab a pizza or something one day after a game? We never get to hang out outside of class. And I was like, oh, okay, that sounds cool. We were in, we did all kinds of things together in class because we had all our same college prep classes and we had some of the same extracurriculars and things like that. And I went home and I said, yeah, my friend so-and-so would like to, sit, maybe we go for pizza after a football game. My father said, absolutely not. And I said, oh, it's not a date, just hanging out with friends. Absolutely not. I looked at him and he said, he's white. Why would a white boy want to go out with you for pizza? I don't trust his intentions. He would take advantage of you. Why would he want you? You hear the stories? Now you just heard 3 of my stories. You've only known me for 2 hours. You heard the story about little Frankie pushing me. I get the spanking. You've heard the story of my mother telling me, oh, they don't make things like that for us. And now you've heard the story of my father telling me, what would a white boy want with you? All he would want with you is to take advantage of you. He could have a white girl. He actually said that he could have a white girl. All of that makes up my race narrative. All of that. So when you use race narratives with clients, you're helping a person tell their story about their own race and other races and the intersectionality. And then it gives you an opportunity to explore how that history is influencing what's going on today. Intersectionality is key. Kimberly Crenshaw brought that. She's an attorney who brought that word into the mental health profession to talk about our identity, because everything intersects. All of our identities intersect, and sometimes we're in a marginalized group, sometimes a privileged group, whatever. So it's a way of bringing this race narrative is a way of bringing things to the foreground. If you want a copy of this, I didn't think to put it in the to prepare it in advance, but if you let me know, I'll make sure that you get copies of the entire document. We are running out of time, so I'm just going to go through this really fast, but this is nearing the end here. How do you self-describe racially or ethnically? Has that changed over time? When you were growing up, how did your parents or your family of origin self-describe racially or ethnically? Do you have an immediate or extended family member that's biracial or multiracial? If so, how would you describe that experience or that relationship? Do you see yourself as marginalized or privileged? And consider whether you have race privilege, economic privilege, both or neither. What was your age and first impression the first time you saw or met a person of another race? What roles have people of other races had in your life, like as a friend, a caregiver, a housekeeper, a teacher, a professional peer, a professional supervisor, a religious leader? That's important. How have they seen other people, and how do they experience other people of other races relative to themselves? Is there a person of another race who's been positively influential in your life, and what kind of influence did they have? What were the explicit messages you took in growing up about your race and about other races? Boy, can I talk about that with those 3 experiences I just gave you as examples. What were the implied messages you took in? Once again, all 3 of my stories that I just told you, and all 3 of those stories were before I graduated high school, 2 before I even got out of elementary school. To what extent did you attempt to cross racial lines? Someone says, what are racial lines? Things that are socially acceptable when it comes to race, voluntarily, when you were younger. So for me to say, you know, this guy and I were going to just grab pizza, and in my mind, it's probably with like a whole bunch of people, you know, the whole group of us. That was, in my dad's mind, that was crossing a racial line. So what was encouraged or discouraged? What was that experience like? What was the outcome of that attempt? To what extent have you crossed racial lines as an adult? By going into a multiracial church, or intentionally moving into a multicultural neighborhood, or staying in a neighborhood that was becoming more multicultural and diverse, and not, you know, not saying we got to move to a better neighborhood. Were you ever forced to cross racial lines? Like the little girl that was forced to leave her mom's classroom and go to an all-white school. What was that experience like? Have you ever been personally victimized by a person of another race? And if so, what effect did that have on your perspectives on race? Have you ever confronted someone about statements or behaviors that you believe to be racist, racially inflammatory, whatever? What was that experience like? And that sometimes that question really challenges people, because sometimes to do that, it costs something. It can cost something in the workplace. It can cost something in families when you confront things that are racially inflammatory. What stereotypes, prejudices, or forms of discrimination do you think you may have personally subscribed to over the years? What might it cost you professionally, socially, relationally, or financially to position yourself differently in controversial race-related conversations? What have been your approaches to handling differences? Do you attempt to be colorblind? Why or why not? What are your current desires or goals for diversity, inclusivity, and equity? What have you taken in from media and culture about BIPOC communities, and how have they shaped your expectations? To what extent has your social location benefited you or limited you? And then this is just a fun one. This is the last one. And it depends on, this is the age thing, because they started making Band-Aids different colors. When was the first time you realized that adhesive bandages did not match all skin tones? Do you have any feelings or interpretations regarding that? And someone will inevitably every time say, well, they make them brown now. And I go, yeah, now. When I was growing up, there's one color Band-Aid. It was supposed to be flesh tone, but it wasn't my flesh tone. Hosiery for ladies, when we used to wear, you know, the hosiery. Flesh tone was not my flesh tone. Flesh tone. You see how white normative, you know, impacts non-whites, hits differently. It causes the differences to stand out, and it says, my norm, what's normative for me, my norm, my needs are otherized. Otherized. What can counselors do? I'm closing up. What can counselors do to avoid race-based diagnostic errors? things we've talked about. Paying attention to the assessments that you're using, the questions that you're asking, looking into things like preterm birth, paying attention to your biases, paying attention to the things that are different lived realities, helping people feel safe, bringing race from the background to the foreground, paying attention to that red hot zone, those roots, because maybe you're looking among the branches for what only appears in the roots, making sure your assessment precedes diagnosis. Cultural humility, use those personal race narratives, pay attention to your biases and manage them. Monitor yourself and the people that you work with for stereotypes. Ask the diagnostic questions that are culturally meaningful. Consider those biological factors around neurodivergent versus neurodevelopmental. Take an ecological approach. What I mean by that is you're looking at the ecosystem for the person. You're looking at processes. You're looking at everything in their life and the various systems that intersect. Don't simply act upon what you expect to see from any client. You expect eating disorder to look a certain way. Don't let diagnostic tools override your clinical judgment. Consult with other professionals. I do a lot of consultations about race and culture. You can refer to those cultural tools in the DSM, like the cultural formulation interview, but you got to use your clinical judgment as well. Okay.
And I think for me, the things that, even more so than like the bigger picture issues, like some of the ways that you just described being able to address challenging situations, right? And like your language of, okay, here's how I'm going to kind of put it out there. And here's how I want to kind of introduce myself, but also introduce the fact that I'm not a person of color and that our life experiences and the way that we see things may be different. And I loved talking about the church as well. And use the phrase of like avoiding the spiritual bypass. And I think like finding those ways to, again, like open up the doors to those conversations of two things can be true at once, right? Like we can hold on to that one, exploring something else.
Yes.
I just want to say thank you so much to LaVerne for her training today and all of the valuable information that she provided on how us as counselors can show cultural humility in our own practice. As a reminder, when the training concludes and you leave the call, you'll be able to click on your CE quiz and post survey. You will need to pass your quiz before you can access your certificate. While you need a passing score, you can retake the quiz if needed until you reach that passing score. You'll be able to find that CE quiz and post survey on your left-hand side. If you do need a copy of your certificate later, you can access it through your profile anytime. LaVerne, Dr. Collins does offer a lot of products and services, which will be linked in the session notes. She is available for speaking engagements and NBCC CE trainings. She has her book, Overlooked: Counselor Insights for the Unspoken Issues in Black American Life. And she also has a podcast called The Multicultural Mindset, which can also be found on YouTube. Thank you, everyone, for attending. And another big thank you to Dr. LaVerne Collins. Thanks for listening, and don't forget that you need a training.
Thank you for joining in on today's training. We look forward to having you join us again. Heart & Solutions is proud to provide CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below.